So today we'll discuss the role of cryotherapy in urology, sir. So predominantly cryotherapy is applied in two malignancies, which is prostate cancer and renal cancers. And this is our new hospital. There is some delay in the slides. We are just going to open later in 2022, sir. It will become one of the biggest hospital in the West Midlands.
Wow.
Yeah, it is known as Midlands Metropolitan Hospital. So cryotherapy is evolving because of the minimally invasive treatment options has become key in most of the treatment options, because always minimally invasive treatment has got less perioperative complications. It's like Stragon stone compared to open surgery. PCNL has got less perioperative complications. So we are trying to make everything into a minimally accessible method. Among the various minimally invasive treatments, cryotherapy is used predominantly in prostate cancer and renal cancers, because other cancers were not very amenable, like for example transitional cancer, because of the non-solid formality of the tumor. It's not very amenable to the cryotherapy. Prostate cancer, as we know, because of increased PSA screening, there is increased incidence of low risk localized prostate cancers. So radical prostatectomy or the whole gland radiotherapy is little bit overkill for these low risk organ confined low Gleason score cancers. And this helps as a nice bridge between the patients who are opting for active surveillance and patients who need a radical option. Regarding the renal cancers also, as of now, there is an increased incidence of T1A, which is less than 4 centimeter tumors, because of increased imaging and incidental tumors found out due to imaging done for the other indications. And the latest report shows almost 70% of the newly diagnosed cancers were all T1A because of the increased use of radiology. Historically speaking, low temperature as a treatment method was started as an anesthetic effect. So a low temperature, like a spray used to anesthetize area so that a small incision can be done by a dermatologist people. I use the same corollary when I do urolift. I keep the lignocaine jelly in a fridge and use a cold lignocaine jelly, so it anesthetizes the urethra and makes the procedure to be done completely under local. And the first person to use the low temperature to treat cancer is Arnott, and predominantly it's used for breast and uterine cancers. Later, we started using the liquid air and liquid oxygen, which is much more controllable and can be used for skin diseases, both therapeutically, like cryotherapying them, and also giving a kind of a blockage for excision. And then cryotherapy applications becomes quite rapidly grown in 1960s when Cooper and Lee found out a proper unit, cryosurgical unit, where they can deliver liquid nitrogen, which produces an excellent cryotherapy temperature of minus 196 degrees Celsius. So this is one of the MCQ questions they will ask for liquid hydrogen temperature for cryotherapy. And then Gardner et al. Initiated the cryotherapy for the urology diseases. It started with for BPH, benign prostate ablation. But then people found that the side effects of the cryotherapy, like injury to the erectile dysfunction, periprostatic nerves, is not acceptable for a benign condition. People are happy to lose the erection or any other side effects for malignant reasons, but not for benign reasons. So the indications for benign slowly dwindled down. In 1980s, Corpan performed experiments to understand how this cryotherapy works. Those freezing studies helped to framework the formulation of this freeze-thaw sequence, which helped the modern cryosurgery to improve further. And then Oink introduced the percutaneous transperineal approach for the prostate. So this prevented unnecessary urethral cryo injuries, and also we have developed advanced third generation cryotherapy machines, which gives urethral warmer. So the urethral mucosa is spared from the cryotherapy effects. So how this cryotherapy works? Mainly works by two methods. The first is by directly damaging the cell membranes and organelles by just brute low temperature. Just like how a cell or a tissue will get die in a high temperature, in low temperature also it damages the cell membrane and organelles directly. Indirectly, it can do by coagulating the small vessels, which results in thrombosis, that results in indirectly vascular necrosis and vascular compromise for the tissues. By lowering the temperature, the cells get dehydrated, the proteins and organelles will get disrupted, so the functioning cell has lost its potency because all the enzymes in the cell can work only at a particular temperature. Ice crystals forms inside the cell, which also result in faster cooling, and it will result in much more wider mechanical damage of the membranes and organelles. When we are repeating the freeze-thaw mechanism, what's happening is first the tissues surrounding that fiber will get cryolyzed, and since there is a next wave of cryotherapy is coming, the tissues are much more wider spread effect is made. So that's why the freeze-thaw mechanism is much better than just a single freezing cryotherapy episode. So that's the advantage of the third generation machines. Vessel walls are damaged and perivascular hydration is lost, and so both mechanical injury and vascular related injury works hand in hand. It results in more permeability, edema, and creates a coagulation cascade. And just like the reperfusion injury which can happen in case of like a transplant, etc., the reperfusion injury by after stopping the cryotherapy, the new blood vessels, when they get reperfusion into the tissue, that results in driving out lot of inflammatory changes, and reperfusion injury causes much more cell damage. And histologically, when we examine the tissues, it shows coagulative necrosis. So in 1996, with vast technological... Yes, sir?
This freeze-thaw,
Yes, sir.
is it done only as one cycle or repeated cycles, freeze-thaw, freeze-thaw?
We can do 3 times, sir. So freeze, thaw, and what is happening is the third generation machines, there is a active temperature monitoring. Sometimes with 3 cycles of freeze, thaw, we reach the temperature, so we are confident that the tissue damage is done. And if the temperature is reached at second cycle itself, then we can stop it, because the third cycle of freeze thaw will cause expansion of the cryo to the outside the desired area. So that's why we have much more control. And this is one of the picture of the third generation cryo machine, where we can control the temperature of the every filament. That is one advantage. So the filament which goes to the center of the prostate cancer can be given comfortably the 190 minus 196 temperature, while the filaments which are going peripherally, we can adjust it to a lower temperature, so that we don't pass outside the cancer margin, and also the erectile dysfunction and perivascular, periprostatic nerve damage is also much less. So that's the advantage of the third generation. Because of this, the AUA 1996 has introduced the guidelines to say that the third generation systems are quite good, minimal morbidity, and it is acceptable both for primary prostate cancer and also salvage treatment. I will say the role is much more good in salvage environment, because we all know post radiotherapy, salvage, if there is a biochemical failure, salvage prostatectomy is quite a challenging surgery, not only for the surgeon, and outcome wise, incontinence and fistula formation, erectile dysfunction formation is so high. Even though you are going to explain the patient quite morbid outcome, a surgeon doesn't want to do the salvage surgery and get those things under his belt. So these are the ideal situations where cryotherapy, the side effects are less, and also the patient gets an image as if like it is done by a machine rather than a human, and any side effects are more acceptable to the patient, and patient won't finger point a surgeon that you did the prostatectomy and I am getting now lifelong incontinence. So there are lots of hidden reasons why it's much more acceptable, I will say, even for the Asian countries on a salvage environment rather than in a primary environment. And I will take it further and say, in a primary environment, if you start applying cryotherapy, again it will reduce the learning curve for the surgeons. Already the number of patients they are getting are not good enough to get the training at a good speed. So the primary is only for very selective patients who are nicely counseled and who are very pro cryo, or a unit which is doing research based studies. Otherwise it has no role for a wider practice. So this picture shows us how the machine works. It's almost like a template biopsy. The gauge is kept, and then with a specific transrectal ultrasound machine, we can focus, and now we can do even this MRI guided. So the technology is sky limit, and as long as you have the investment and the infrastructure, the technology is really sky limit. And you can control the temperature, you can control the freeze thaw cycle, you can actively monitor the urethral temperature. After placing the filament, we should do a flexible cystoscopy to make sure none of the
filaments go directly into the prostate.
directly into the prostate percutaneously.
And the rectal temperature is monitored.
Rectal temperature monitored, urethral temperature also monitored. So, yeah, and if the
is monitored live by the how this ice ball is forming. That is monitored by the ultrasound.
If the rectal and urethral temperature are achieving low in the second freeze thaw itself, they will stop. Even though oncologically the outcome may be slightly inferior, but otherwise we will develop a fistula. And urethral injury and rectal fistula are much more morbid for the patient. And these patients, even if there is a biochemical recurrence, we have the fallback of hormone treatment and androgen deprivation treatment to help them for the rest of the life. So after placing the filaments, we need to do a flexible cystoscopy to make sure none of the cryotherapy filaments have punctured the urethra. These are all the routine things. And this is the transrectal image, both cross-sectional and longitudinal, which will tell the individual filaments. And after the procedure is over, all the filaments were removed, and a good compression has to be given for at least like 2 to 5 minutes to prevent hematoma formation, because we have no way access inside the system, because periprostatic bleeding will be there. And it's almost like a day procedure. If the procedure is done quite early in the day, patient should be able to go home the same day. We'll keep a catheter for overnight, and because if there is a small bruise or something, it will help the patient to have a healing in 24 hours. I'll just discuss some results. As far as the primary whole gland cryotherapy is concerned, there are systematic reviews which shows they are good for clinically localized prostate cancer, and the effectiveness is low because it is never going to be as good as a properly done radical prostatectomy. So definitely, like for like, it will never be equivalent to a radical prostatectomy. But patients who doesn't want radical prostatectomy, don't want to have a big procedure, they want to go something in between the active surveillance and radical options, this may be the only choice available. And there are randomized trial by Chin et al. Comparing the radiation treatment with the cryotherapy for T2C and 3B prostate cancer. The disease-specific survival rate and overall survival rate were very similar, but disease-free survival rate is higher in the radiation treatment. That's why, as far as oncology outcome is concerned, radical surgery, radical radiotherapy will be always superior to cryotherapy. Patients should know that. But whether that disease-free survival reflect into patients' longevity means no. Patients' longevity is preserved because we have androgen deprivation treatment to fall back. And these studies, they used the same cutoff like radiation treatment, because the gland is maintained. There will be some amount of benign tissue producing the PSA. We can't get the PSA results like non-accessible less than 0.001 like radical prostatectomy. So they are accepting values like 0.5 as a clinically successful outcome for radical cryotherapy, just like radiotherapy, since the gland is maintained. And retrospective reviews have shown that 10-year survival rate for negative biopsy status is 73%. And now we got this cold registry, which stands for Cryo Online Database. Since the people are doing this cryotherapy here and there, they all join together to produce a good volume, so that it's more easy to monitor. It will help them to promote the cryosurgery as a good option nationally and internationally. And also it gives them a subset analysis, so that if a center is not performing well, they can revise the technique, or if the machine is like first generation, second generation, they can invest for a third generation. It's helpful in both. Unless if this cold registry is there, they won't get a volume to present as a data. As if the volume is not there in long term, cryotherapy will slowly fade away. And as I said, the third generation technology is much more superior. The incontinence requiring pads is only 3%, urge incontinence is 5%, and transient incontinence, urinary retention is only 3%, rectal pain 2%. Previously, all these side effects were in the region of 10% to 15%, so now it's reduced. So this is the area salvage cryotherapy, where especially if the surgeon doesn't want to have the salvage prostatectomy in his hands, the cryotherapy has a good role, and the as expected rectal injury, incontinence, anastomotic strictures will be definitely higher compared to the non-salvage like primary cryotherapy. But incontinence rate and fistula rates are much less anyway, because we have the mechanism to monitor the temperature around the sphincter, so the sphincter is nicely preserved. 5-year survival rate for salvage is 97% and biochemical failure is 44%. So almost half of the patients had biochemical failure, they had androgen deprivation treatment. And again, the results were taken from the cold registry. 8.2% of the patients required post-treatment hormone ablation. So that's the failure rate. And we've got excellent thermocouple monitors in sphincter area. So urinary complications are now completely into a single digit as far as third generation machines are concerned. So importance after cryotherapy is still high, because patient already had radiotherapy, which itself may have damaged the erection problem. So it's like a super added one. So we can't expect, compared to primary cryotherapy, we can almost assure the patient that erection will be maintained, while we can't do that for salvage treatment options. And now this is the area where cryotherapy again has a very unique role. So if there is a patient who underwent a proper multifocal transperineal biopsies, if all the tumor were present only on one side, there is a role for focal cryotherapy. So, but we all know, we all agree that prostate cancer is a multifocal disease. If you do a limited biopsies of say 6+6 on both sides, something like that, and if only right side shows 4 out of 6 cores positive, we can definitely say the left side also there will be some prostate cancer in peripheral zone, which we haven't managed to biopsy. But if the patient had a proper transperineal biopsy, like 50 cores right side, 50 cores left side, unfortunately if the patient had only left side positive, right side is completely negative, those are the patients where we can discuss the focal therapy. Of course, we should tell them that prostate cancer is a multifocal disease. We have done extensive biopsy, but we are not able to find anything on the right side, so we'll do a focal therapy on the left side. So these patients will have a definite erection preservation because the nerve is untouched on one side. So this is not possible in case of like a semi-ablation radiotherapy, or surgery wise we can't do a partial ablation. So I will say
it is accepted as standard of care, do one side.
It is accepted provided a patient had a proper 100 core biopsy. Saturation biopsy, 100 cores, 120 cores, and so it's almost like a needle ablation of the prostate.
Yeah.
And the major challenge in these patients is how to anatomically localize the glands with tumor, because we do the saturation biopsy. It is not possible to send the saturation biopsy everything into a labeled container. We will label it as maximum 6 zones for left and right. So if 2 zones are positive, means we have to ablate 2 full zones, of which there will be some benign glands also will get ablated. So focal therapy has its own disadvantage. But now we have this MRI guided cryotherapy. So we can again do an MRI. We need to do a pre-saturation biopsy MRI and post-saturation biopsy on table MRI. And as you know, even a simple transrectal biopsy MRI will show a lot of false positive results, etc., because of the biopsy related one. If a patient had a complete saturation biopsy, you can explain that how much the MRI will get false results. But to a certain extent, you can identify the lesions, and we can focus the cryotherapy. That's why focal cryotherapy, again very selective. I will say it is still in a very early stage. But patients who are so particular, I understand the consequences, I understand there may be a high biochemical failure rate from the opposite side. I may develop a tumor on the opposite side, which may end up me requiring a radical prostatectomy or radiotherapy, full gland in future. But those who are accepting it, it's a good choice. It just falls between active surveillance and radical treatment. Active surveillance is good without any side effects, but those who are apprehensive, if they want to follow a middle path, there is some role in it. And AUA guidelines have, this is for the renal neoplasms. So coming to the kidney cancers, this is studied very extensively in animal models. Unlike for prostate cancer, it was not used to treat neoplasms until Ichida's publication. It's a main publication which has proven the role of cryotherapy in kidney cancers. The main advantage is there is less bleeding complications, and the need for the partial these patients are only like a suitable less than 4 centimeter T1A tumors. So the main, again, as a surgeon, my feeling is this kind of cryotherapy for T1A tumors will take away your efficiency of numbers of doing partial nephrectomy, whether it's open or laparoscopic or robotic guided, because the numbers are very, very important in Western countries. So that's why they do a lot of centralization, and if two surgeons are doing low volume in two different units, they were forced to make it into a one unit, so that at least the staffs are confident in the procedure and the surgeons can travel. And post-op also, it's the same staffs who are taking care of a patient, so they know partial nephrectomy means this is the protocol, rather than training two different teams actually. So the main advantage is preventing the complications, and the disadvantage is none of the printed paper will say that surgeons will lose the learning curve and numbers, but that's a open secret actually. So AUA guidelines now list partial nephrectomy as a standard of the care of the management for T1A tumors as a gold standard, and then due to increased utilization of cross-section images, we are getting 70% of the tumors were T1A. So there is a role for these kind of tumors in a very selective population, like for example solitary kidney, very elderly woman or man who doesn't want to have a partial nephrectomy or not fit for partial nephrectomy. So these are all the patients where cryosurgery has some recommendations. So mainly people with multiple comorbidities, elderly people and single kidney, there is some role. And outcome wise, again, if these patients were appropriately marked and if the treatment is done with a 0.5 centimeter margin involving the outside, the outcome is almost could be equivalent, because there is no problems like urethral cooling or sphincter injury or periprostatic nerve injury resulting in erectile dysfunction. So procedure is much more straightforward. For a radiologist who is doing regular prostate cryoablation, whether focal or whole gland, renal ablation will be more easier for him, because once he had an access, then it's much more straightforward compared to prostate, not very challenging. And so the data is there comparing the laparoscopic cryoablation, percutaneous cryoablation. Laparoscopic cryoablation always involves a surgeon, while percutaneous is done by the radiologist. And the outcomes, if you compare again laparoscopic,
do it under ultrasound guidance or CT guidance?
Ultrasound guided, sir. So laparoscopic probe, ultrasound, and then if
Monitor.
the monitored, and then continuous monitoring.
Ultrasound.
Yeah, and we can keep a temperature probe in the hilum also, just to make sure that the hilum is not getting frozen. And this is suitable for completely intrarenal tumor, where if it is not a pedunculated one, if the renal score or the scores are not supportive of a very easy partial nephrectomy, then this will be a much more better choice. And there are plenty of studies, again systematic analysis, who have done when they are comparing it to the laparoscopic partial nephrectomy, the results were comparable. And when they treated with laparoscopic cryoablation is much more more specific, and it's much more surgeon driven compared to the percutaneous one. So peri and postoperative complications were mainly like we need to make sure that the bowel is nicely away, which can be done by laparoscopically. They can take the bowel away and make sure that the ice ball is not touching the pelvic ileal system, otherwise it can create urine leak. So if there is a urine leak, again we need to make sure that the patient is appropriately stented or nephrostomized to make sure that the pelvic ileal system is healing well. I think the Desai et al. Paper should be from MPUH. And the EGFR drop in laparoscopic partial nephrectomy is around like 14 to 7%, so it is quite comparable. And laparoscopic partial nephrectomy is associated with increased blood loss because we are opening the renal surface, and also we are creating the hemostasis. While in case of laparoscopic cryoablation, the whole process itself like a hemostatic one. So that's one advantage. So bleeding is quite minimal. And hilar clamping can cause renal ischemia and loss of renal tissue function in the normal part of the preserved kidney also, while hilar clamping is not necessary with laparoscopic cryoablation. So in conclusion, cryotherapy is a good example of treatment method which is mainly here because of the development of technology. For example, if we don't have this third generation cryotherapy machines where the probes can be designated particular temperature and urethral warming and temperature probe to measure the sphincter temperature and rectal cooling, if this technology is not there, with first generation and second generation, by now this method will be in bucket and nobody will be following it. It's purely because of technology advances we are still holding cryotherapy as one of the option. And there are a lot of confounding factors because in prostate cancer, radical prostatectomy, we know that we want PSA to be 0 or non-accessible, NA they say. While for radiotherapy, we know that Astro and Phoenix criteria, and we have like a NADID value, and then +2 means it's a biochemical failure. Since cryotherapy falls in between, those guys have intelligently selected the radiotherapy outcome biochemical failure criteria as the cryotherapy failure because that's more friendly. That gives a more margin to say the biochemical failure is less. If they use the PSA should be non-accessible or less than 0.01, then biochemical failure will be very, very high. But the main thing what we need to understand is the importance is not just the biochemical failure alone, whether it really translates into patients' longevity problem, whether it really affects disease-specific survival, that's the question. That is not there. So patients are still having good disease-specific survival, and patients are getting the androgen deprivation treatment whenever there is a biochemical recurrence. So biochemical recurrence is only like a news. It's not transferring into disease-specific survival. That's one advantage of the cryotherapy. So the third generation machines are the good ones which is holding the port. As far as the partial nephrectomy and laparoscopic cryoablation is concerned, it's good for any tumors less than T1A. We are expanding it slightly to T1B also in a very elderly woman who is not fit for it, instead of just following them with active surveillance.
You can do 2 sittings there?
Pardon, sir?
You all do in 1 sitting or 2 sittings?
No, we can have multiple probes, sir.
Okay.
Multiple probe parallelly. So, I mean, not every radiologist will be happy with that. T1A is the standard one, but if the tumor is like 5.5, they don't want to create a watershed area for 4 centimeter. And especially, we will initially, if the patient is absolutely not fit, we will try to follow him with one other CT in 6 months' time and 1 year time. But if the growth is more than 0.3 millimeter in a year, that means the patient is definitely going to have a very rapid growing tumor. So those are the tumors where it's better to do something rather than just keeping them on active surveillance. And to clarify the role of the cryotherapy in treating prostate cancer, it all depends upon the commitment of the team and non-availability of a proper surgeon, I will say. Next time I will do radiofrequency ablation, sir. That will be almost overlapping. Only the technology is different, but the outcomes and mechanisms, everything, the logistics are almost same.
Thank you.
Yes, sir.
So you see where you are lacking ever in your theory, both of you.
This may be a definite theory question.
That's why I requested Anand to. So now you
Formed an
have
idea.
some idea what it is. Not only general knowledge, but also specific urology knowledge. Kidney, prostate.
The problem is the Campbell book won't give much because
You
it's
have to read there. You have to read other books.
it's a radiology based topic actually, and that is one intervention radiology based topic. And there are some MCQs, as I said.
AUV update series and all
AUV
that will be there
updates.
somewhere.
Mm.
Look around, you find it.
The -196 degrees Celsius for liquid nitrogen, that's a very common MCQ we ask. So those are all the things to concentrate.
Yeah, so we have to go to other building.
Okay.
And let us go down.